Good afternoon, everyone. My name is Soura Bhattacharyya. I'm here to share my team's work in building an open source mobile-first platform for public health. A bit about me. I'm an engineer and an MBA by training, though an entrepreneur by trade. 11 years ago, I started Lattice Innovations, which works in digital health. We're a small team, about 25 people based in Delhi in India. Our projects are spread across the US, India, East Africa, and the Pacific Islands. Before starting Lattice, I spent 8 years in two very different healthcare contexts. I ran a secondary care hospital chain in rural India. And before that, I developed laser microsurgery tools in the US. So onto the subject matter of this talk. Agni is an open source mobile first platform. Agni is designed for offline use. It uses evidence-based guidelines for clinical workflows and uses HL7 FHIR. Now, by public health, and I referred to public health in the introduction slide. So in terms of public health, I referred to public health at the very start of my presentation. So by that, we mean that our focus is on supporting community health workers as well as primary healthcare providers. And secondly, by public health, we focus a lot more on risk management and prevention over the curative aspects of healthcare. And this part, this focus on risk management actually informs much of what we do in terms of design. And I'll spend some time talking about that in detail in a few minutes. So before we jump into the details of what the platform is, what it does, and what opportunities it opens up to those wishing to utilize it, given that it's an open source project, I just wanted to spend a few minutes talking about the motivation behind doing this work or even starting this body of work. So, I mean, one part of the motivation is very much informed by my personal experience. I had the chance to work in Tamil Nadu, in Andhra, in West Bengal, and time and time again, I saw that there was a large gap, a large gulf between how mature digital tools were in the public health space compared to the for-profit sector. COVID really underscored this, and I think it highlighted to me, and I think to many of us, both the gaps and the scope for new solutions in the public health space. And I'd also like to underscore one more thing is that digital health and digital identity are two very strongly linked elements. This is something that we've been able to understand as we work with both regional and national governments. And being able to navigate this marriage of these two different data systems is really crucial from a public health perspective. Now, this statement might seem kind of self-evident, but I think it's something that I've observed firsthand many times, which is that public health gets a watered down hospital IT system rather than getting systems that are developed from scratch with its needs in mind. So I think when I'll use one example real quick. So imagine, you walk into a primary health center and you see that they're using a system that's requires an internet all the time and only works on a desktop. And the expectation is somehow that the community health worker will come in, once a week or a few times a week to fill in their information in this system. So when hardware is a limitation, when network connectivity is a limitation, we have to think very differently about what public health requires. So in essence, this slide is more about what not to do, but then we'll switch gears to what to do. I think one of the key things on the to-do list is designing for transparency and openness. Now, by transparency, if I take a personal example, I will say that I'm transparent if my motivations are open to you, meaning that you can understand where I'm coming from. And secondly, I can say that I'm open if I am actually receptive to your inputs. So if I just take that personal example and apply it to a digital system, then a digital system can be said to be transparent when its inner workings are visible. And this is particularly important where security and privacy is concerned, because I think that's a core part of risk when it comes to handling health data. And secondly, from an openness point of view, a system must be able to take inputs from other systems, other protocols, other knowledge banks about healthcare. And therefore, for me, transparency and openness, these two demands that are placed on tools for public health, naturally translate to a requirement for open source and a need for standards-based design. So open source is what our project is, and standards-based design is what we have followed, particularly in using HL7 FHIR as the data standard or the data model that governs the entire system. And our focus has been on using an out-of-the-box, boilerplate FHIR configuration so that we don't end up introducing a lot of customization, and rather we utilize FHIR for the full set of capabilities that it inherently gives us. A quick slide about the conceptual framework. A couple of minutes ago, I mentioned our focus on assessing risk. So we see wellness and illness as a continuum, rather than a static kind of an event. And therefore, if wellness and illness is a continuum, there's a need for progressive risk assessment. Progressive meaning that it happens periodically, frequently, and with small data points from diverse sources that enrich our understanding of whether an individual is at low risk, moderate risk, high risk of a particular disease or condition. So this kind of a dynamic system needs to be able to incorporate lightweight data relatively quickly. It also has to think about wellness, not just illness, in the sense that if you look at conventional hospital-based care, rather than healthcare, it can better be called illness care because it starts when something has already gone wrong. In contrast, public health is has its focus on prevention, and therefore it's about assessing risk and understanding where somebody is on this continuum from being well to being ill. I'll quote one example just to underscore why this is important to consider in terms of system design. So a lot of the questionnaires that are used today, and well-validated clinical questionnaires with hundreds of thousands of data points behind them, they'll ask on a cardiac health assessment question, did you ever smoke in the last 10 years? Now, a more appropriate question to my mind is asking somebody, do they smoke today and how much do they smoke every 3 months? Trying to get one-shot data about 10 years of history gives you a lot less fidelity, a lot less accuracy of reporting. Whereas if we were able to think about systems that ask important questions frequently and in a lightweight, low-touch manner, then we are more likely to build a more accurate risk profile of a person, in this example for cardiac disease. Now, moving on, I'll jump into some of the key features of what we've developed, but my intent here is not to talk about what we've achieved, but rather the problems we've set out to solve. So as I go over some of the key features of Agni, I will constantly attempt to back out to the problem we were trying to address. And also, I want to just acknowledge here that what we have built is one answer based on one perspective. So my goal over the next few slides is to use what we have solved to illuminate the problem. We need to move from solution back to problem because I think that's of more broader interest to the audience here. So the first aspect that I touched on in the very opening slide was that the system is offline first. Now, offline first requires data storage within the mobile app. That's an obvious statement. But when you build for that, you have to optimize the database for mobile, which means you have to figure out how to store data in the most compact manner possible. And that solution is often not directly compatible with a data standard like FHIR. So you also need to figure out a way to translate between how the mobile is storing data and what FHIR is recommending. And that interface and that interaction is a FHIR facade server. So you have to think about an interface between mobile data storage, server data storage. That's on the technical part. I think that's, in a sense, the smaller and also well-solved part of the problem. The bigger question is really how do you balance between speed and convenience, on the one hand, for the healthcare practitioner, and privacy of the patient. What I mean by this is that the moment we start storing data offline, questions about how long does the data have to stay stored, in what event does data get purged, how much data is too much or too little, these all have to be thought through, and this certainly is very much context dependent. So for example, let's say a primary healthcare system serves 5,000 patients, and there are 3 community health workers working in that, associated with that primary healthcare system. So maybe all 3 of them need all 5,000 patients' data on their phone. But then what happens when somebody moves out, somebody moves in? What happens when patients from an adjoining block or an adjoining administrative unit actually come to that primary healthcare system to get care. Because often healthcare consumption almost necessarily does not follow the boundaries and the lines that we draw from an administrative point of view. People go to those healthcare centers that they find accessible. So, the catchment area of a primary health center is not defined by the administrative boundaries that are drawn around it. And so these are the kinds of questions that have to be thought through and answered to think about an offline first system, and to ensure that we, again, find the right balance between speed and convenience of use and data security and privacy. The next area that we focused on was linking beneficiaries within a household. So you could note that I use the word beneficiaries, not patients. And this is, again, an important distinction when we think about public health, because often you want to start talking about people well before they become a patient. And the second thing is, I've used household here, and we've designed household as a shorthand for 3 types of relationships. But those 3 relationships have to be understood independently. Each of them have a bearing on how public health works. The first kind of relationship is a legal one. The second kind is a biological one. The third is a spatial one, in space, proximity. So a legal relationship is often important from a program delivery point of view, because governments often think in terms of a household where they're delivering benefits. A biological relationship is often critical for understanding genetic disease and looking at risk factors. Cardiac disease is a classic example where there is a hereditary risk. And finally, a spatial relationship was made, the value of that and tracking that was made abundantly clear to us during COVID. So any kind of infectious disease, automatically proximity, shared water, shared air, shared homes, they all become very critical. So we've done a shorthand here in terms of thinking about a household as something that combines all 3, legal, biological, spatial, but all of these 3 aspects actually have bearings on how public health functions. The other thing that we have thought of in some detail, and I'd like to hold up as an important problem or an important point of consideration, is that the household is constructed of individuals. So people come together to form a household, they can dissolve, they can recombine, and this has to be thought through again from an individual's aggregating to a household's perspective, and not the other way around. And that also, and that's something that we've again thought of in the design to make sure that as you group people together, a household is formed. As you divide people up, you can create new households. This slide on scheduling, I'll just cover along with the next one. Again, the idea is not to focus on the feature, but to really talk about the underlying problem. So the other aspect, or the next aspect to talk about, is scheduling. And I'll cover this in combination with queue management, because again, the idea is not to get deep into the feature set of the system, but rather talk more broadly about the problem space. So there's really 2 problems that need to be addressed in the primary healthcare domain. One is that you need some level of lightweight appointment management that layers on top of what is mostly a walk-in system. So if let's say PHC sees about 50 patients in a day, 48 of them will be people who have walked in. 2 might be people who have been scheduled for some sort of a follow-up. So you have to optimize for a walk-in dominant scenario. So it's a lot more about managing a waiting queue than about managing an appointment book. So I think that's kind of the first takeaway. The second is, when you think about community health workers, for them, scheduling is about route management, which is deciding which households they need to see on a given day. So that is the second aspect of queue management. Again, we focused in this particular module on the primary healthcare on the PHC flow, but the community health worker would need another additional way of supporting their work. Next, we have standards-based risk assessment. So here we've used WHO's 10 protocols. That's the package for essential non-communicable disease. It's been out there for a long time, very well established. But I think what is interesting, which this is what we needed to do to make sure that we followed what is already well-established science. But the underlying problem worth solving to me really is, what is the least amount of information that updates a risk prediction? So I'll use again an example to illustrate. So let's say we are in an urban setting. You have a beneficiary who's male, who's 65 years old, no overt symptoms of any illness. What is the next most important data point about him? Is it a blood pressure measurement? Is it a fasting blood glucose? Is it a smoking status? So really, what is it a measure of obesity? So height, weight, waist measurement. What is the next most valuable data point? And as you ask more questions, as you incrementally get more information about an individual, can you update the next question that you wish to ask? So that kind of a dynamic environment would be extremely valuable, because often there is a tremendous paucity of time in terms of data acquisition. So even a 10-minute questionnaire can be challenging in certain scenarios. Secondly, there's often not enough scope to self-report information. So can we combine the patient themselves or the beneficiaries as source of information with the healthcare practitioner? So I think these have to inform how these standards develop and evolve. And that's a long journey, but I think it's a necessary one. And we have to think, therefore, about more atomic information and more precise measurement. The next piece is about using the WHO essential medicines list. You'll see that the word WHO is coming in a lot, but that's basically because we wanted to utilize as many open source information repositories as we could, and I'll talk about a few more that I think are extremely valuable. Now, in prescribing from the WHO EML, great, you take a bunch of data, you put it in. But I think there's, again, a lot of room here for problems worth solving. For example, how do you do better stewardship of antibiotic administration? How do you help people look at drug-drug interactions? How do you help people factor in adverse drug reactions? So a lot of this information, I feel, is, the tooling is there for tertiary care systems, but it's really missing for primary care and community healthcare. Flexibility in dispensing flow is also valuable for public health systems. Often dispensing is a matter of cost, not of income, because the access to drugs is included within a program. So I think that's important. I mean, and from flexibility, we need to make it easy for the pharmacists to track what standard medicines have been given and what are missing. And finally, this is, I'll conclude with this comment that data sharing across platforms. We talked about incremental information gathering. This is just a quick slide to show how, if we just focus on vitals, there's a lot of common vitals that inform risk of various diseases at the same time, concurrently. And public health tends to be program focused. So you will run a CVD screening program, you might run a COVID screening and vaccination camp, you'll run diabetes checkup clinics, you run an immunization program or do a child health and wellness sessions. But the data that you capture is usable across all. So how do we build a comprehensive risk profile and yet enable some kind of programmatic focus? So that's, I think, also it's a large problem statement, but I think one that certainly is worth solving with. Next up, I want to spend a quick takeaway slide for you. I think population enumeration and understanding identity is strongly tied to public health. That's a key message that I want to convey. We have to think in terms of beneficiaries, not just patients, because we are thinking about wellness and well-being of an entire population base that the health system is serving. For us, a personal takeaway was that even though FHIR is, in one sense, developed for hospital-based care, it's possible to build a focused, dedicated public health application with zero customization. And that speaks to the depth to which the FHIR schema goes in terms of capturing healthcare scenarios. And finally, I'll conclude with the note about sharing clinical endpoints across program verticals that I showed in the last slide. The last 3 or 4 slides, I want to talk more about opportunities for where I think we wish to go, but I also hope that people listening in would also want to go with us, participate in our effort to build better public health tooling. The first of these themes is interoperability, an evident, obvious one. We've talked about how there needs to be openness when it comes to having a system, but to be more specific, DPGs, or Digital Public Goods. This is a program funded by the UNDP, and that has a repository of open source tools and technologies and data sets from across the world. So DPGs provide a really good baseline for thinking about interop. I have highlighted three that I personally admire and appreciate and watch closely in terms of their success and their growth. One is the Open CRBS. This is a civil registry system, so birth and death registry, marriage registry. Again, a foundational part of civil services, but one that has a tremendous linkage with health, because birth and death, health, population baselining, those are all kind of very tightly tied together. The other is MOSIP. That's an identity management platform, has had a large deployment in the Philippines. Fantastic work done there. The WHO Digital Adaptation Kit focuses on particular disease areas. So for instance, the WHO DAC for maternal and child health is out there. There are others which are being worked on and being published as we go along. The second is area of interop is also to look at public-private data interfaces. So in India, we have the ABHA system, and there's an attempt to build a common core of data exchange, but I think building for those kinds of common core government systems is really valuable. And the third point, this is based on our observations of what we see UN agencies working a lot on, which is supply chain systems, especially life-saving drugs. So if you think about primary and community care, then there's a natural linkage with supply chain systems, particularly life-saving drugs, vaccines, ARV therapies for HIV/AIDS, and TB medication. The second theme where I think there's a lot of scope for future work is risk management. I think one of this is, if we have thought about a risk profiling system, then I think it has a lot of it can act as a really valuable input to how we think about building risk profiles for individuals and how we think about insuring for health risk. The second part of risk management is, I would say, internal, in the sense that data privacy and security. And I'd particularly highlight the point that a health system has to function even in the absence of digital systems, in that we cannot mandate digital systems as gating somebody's right for their access to health. So these are two different aspects of risk. One is kind of a patient-centric and an insurance-centric view of risk. The other is a system risk, but both of them have a lot more that we can do. The third theme, which is AI as a mediator, and this is where AI really can shine, because FHIR provides us with a structured data set, but importantly, the users, they need flexibility to interact in whatever medium that they find most convenient. So can users be allowed to speak to the system? Can videos be interpreted? Can handwritten notes be translated into structured data? This entire interface layer is somewhere that we can have continuous improvement, where AI acts as an interpreter of unstructured data and puts it in a structured format. In a primary healthcare system, one huge advantage is over, let's say a tertiary care system, is that the lexicon is a lot narrower. So it's my belief that we can build systems with higher fidelity and lower cost, compared to a tertiary care system, which has to handle a much broader variety of possible inputs. So the band of what has to be processed coming in is narrower in the case of primary care and case of public health. And that can be also a point of leverage for the use of AI. The second aspect is the obvious use of AI tools for analysis of structured data, but also to be able to output data in a structured form. So it's, I think, structured data, flexible analysis back to structured data output. This is, I think, another place where AI would be extremely valuable for early detection of trends. So to summarize, the key takeaways that I have in terms of scope for further work is AI as an interface between structured data and user-centric design, user-facing elements. The second point I would emphasize is we have to do an 80 of 80 kind of an approach, which is target 80% of the healthcare scenarios faced by 80% of all people, which is a very different paradigm from trying to do, the 1% for the 1%. And I think I can want to say that our way is one way to solve a portion of a really complex set of problems. So we welcome the opportunity to collaborate with those listening in to expand the relevance. And finally, I'd like to conclude with a big thank you to John Snow for allowing us to be part of this session, this edition of the Health AI Talks. Thank you very much.